All right, thank you for joining. So with that, we'll introduce our Director of Workforce Transformation, Diane Hank.
Good afternoon, everyone. I want to thank you for joining us for MSD Info Session number 8, where we'll be hearing about cultural competency today. But before we begin, I just want to remind you that if you have not been able to watch sessions 1 through 7, they are posted on the OPWDD website. I want to tell you that our next session will be on April 11th, and that will be on focusing on enrollment and consent and really trying to drill down to provide answers to your questions. We know that we're just about to embark on that enrollment process and trainings are being rolled out. So we anticipate that you will have questions and we'll do our very best to help guide you through that. The next session, we have not identified the topic yet, only because we want to be very sensitive to and aware of what the needs are out there in the field. So we'll develop that topic decision based on what we are learning from all of you. So if you want to register for those or view the existing webinars, you go to the link that's listed here in the PowerPoint slide. And for today then, I'm going to move ahead and I'd like to introduce you to the presenters for Cultural Competence for Care Managers. Today it will be presented by Noelia Mango from the New York Association of Emerging and Multicultural Providers. So thank you, Noelia and team of panelists. Why don't you go ahead and share with us today?
Thank you, Diane. Good afternoon, everyone. My name is Noelia Mango, and I am a consultant for the New York Association of Emerging and Multicultural Providers, or NIAMP. Today I'll introduce the basic principles of cultural competence as part of OPWDD's ongoing series of information sessions being provided to help MSCs transition to care managers. Please keep in mind that cultural competence is a broad subject that can be covered in numerous in-depth training sessions, but today's session is really an introductory one. Our goal is to introduce some of the basics of what it takes to be a culturally responsive and culturally proficient care manager, so that individuals from various cultural groups are supported appropriately. We'll introduce different strategies to deliver cross-cultural care and supports, key concepts such as healthcare disparities and social determinants of health, and we'll also go over some of the learning objectives written for this particular skill building area in OPWDD's upcoming training guide. Today's agenda begins with defining the terms cultural competence and cultural humility. Then I'll walk you through the 3 stages and the 6 levels of cultural competency development. These will set the stage for understanding some of the most common cultural competency frameworks called the identity development models. Next, I'll introduce the 7 dimensions of diversity, which are divided into 2 categories: immutable dimensions and cross-cutting dimensions. Then we'll define the terms healthcare disparities and social determinants of health. We'll define these in broad terms. Care managers should be aware of how these 2 concepts significantly impact the quality and effectiveness of the services they provide. Finally, we'll go over the important values that culturally competent care managers need to uphold. Once the presentation is over, OPWDD and the NIAMP team will take your questions. Now, before we dive into the first topic, I'd like to begin by asking the following question. Would you support an individual with a severe or profound intellectual disability the same way you would support an individual with more abilities? If you answered no, you're correct, for the following reasons. 4 medical conditions that are common among individuals with IBD are constipation, aspiration, dehydration, and seizures. These 4 conditions can lead to serious medical complications, and they can prove to be fatal if not recognized timely and treated appropriately. Care managers are encouraged to recognize when individuals experience one of these 4 conditions and pay even closer attention to those individuals with severe and profound intellectual disabilities. Many individuals with severe or profound IBD have insufficient mechanical means to chew food, putting them at much higher risk for constipation, dehydration, and aspiration-related issues. Relevant literature suggests that constipation can cause coexisting symptoms such as fever, anorexia, vomiting, pneumonia, seizures, and a decreased level of consciousness. Unfortunately, these symptoms are often not easily expressed by individuals with severe or profound IDD. Behavioral outbursts may be the only way an individual communicates discomfort, depending on the severity of the IDD, and this is why many medical conditions actually present as behavioral conditions in individuals with IDD. If an individual is at risk for aspiration, symptoms would include coughing after swallowing solid food or liquids, and recurrent pneumonia. Aspiration pneumonia is considered to be one of the main risk factors that contributes to acute lung injury and acute respiratory distress syndrome. Research suggests that dehydration can happen more quickly among individuals with IDD due to their already vulnerable physiologic state. So this is why it's crucial to understand how individuals with IDD communicate their needs, especially those with severe or profound intellectual disabilities. Understanding the severity of an individual's conditions allows a care manager to further tailor the life plan to specific needs and supports. By contrast, studies have shown that individuals with more abilities are at high risk of obesity, along with women, people with Down syndrome, and people living in less restrictive settings. Multiple secondary conditions, such as obesity, pain, and depression, may limit participation in health-promoting routines and lead to acute episodes of emergency department visits and hospitalizations. Speaking of hospitalizations, people with intellectual disabilities discharged from hospitals require 4 times as much workload from primary care as people without intellectual disabilities. So this would include more follow-up appointments, more home visits, telephone contacts, and consultations with nurses, and not to mention that prescribing costs are actually 6 times greater for this population. Again, understanding that certain individuals are at higher risk of obesity would call for different and specific health-promoting supports in the life plan. Overall, aggressive treatment may be required for individuals with severe or profound intellectual disabilities, mainly due to the difficulties they have in communicating symptoms, which may actually lead to a rapid worsening of her or his condition. Research shows that about 37% of adults with intellectual disabilities and 80% of adults with Down syndrome have unhealthy teeth and gums. Care managers, in collaboration with the clinical or medical teams in and outside the CCO, must continue to decrease these percentages by establishing the necessary aggressive treatments. Now that we've discussed some health trends in the IDD population, let's talk about why it's important to understand cultural trends. Cultural competence is defined as the ongoing capacity of healthcare systems, organizations, and professionals to provide diverse populations with high-quality care that is safe, person and family-centered, evidence-based, and equitable. This means that every single key player in each individual circle of support, including care managers, must provide services to all individuals and their families in a manner that is free from cultural biases and stereotypes, while relying on evidence-based clinical and medical practices. As shown on the right, cultural humility refers to a lifelong process of self-reflection, self-critique, and respectful partnering with service recipients. 3 factors that guide us toward cultural humility are, first, a lifelong commitment to self-evaluation and self-critique. So this implies that we're never actually finished learning. We never arrive at a point where we are done learning. Second, a desire to fix power imbalances. When care managers interview individuals, the individual and the family are the experts on the individual's life, strengths, personal history, and preferences. Both the individual and the care manager must collaborate and learn from each other for best outcomes. And third, cultural humility includes aspiring to develop partnerships with people and groups who advocate for others. Cultural humility, by definition, is really larger than our individual selves. We must advocate for it systemically. Care managers, like clinicians, have a responsibility to recognize and value the diversity of all individuals served. Therefore, a culturally sensitive care manager recognizes specific cultural needs and is sensitive, not resistant to them. There are 3 stages that lead to cultural competency. First, a care manager should have cultural knowledge. At this stage, the care manager becomes familiar with the cultural characteristics, history, values, belief systems, and behaviors of the individual's ethnic group. Once a care manager gains cultural knowledge, she or he is to be more culturally aware. At this stage, the care manager has developed sensitivity and understanding of another ethnic group. The third and last stage is cultural sensitivity, where a care manager acknowledges the cultural differences and similarities that exist without assigning values such as better or worse, or right or wrong. By the third stage, a care manager is aware of her or his own cultural biases and ensures they do not impede or negatively impact care coordination. Once all stages are completed, the care manager further achieves cultural competency. But keep in mind that competency is really an ongoing learning process. Next are those 6 levels of cultural competency. The 6 levels illustrate how cultural competence can be developed in a progression that starts in destructiveness and ends in proficiency. The goal is to have care managers work through the necessary levels to ultimately achieve proficiency. Not everyone actually starts at level 1. Level 1 is destructiveness, which is about purposeful destruction and dehumanization of other cultures. It's the total eradication of other cultures. And unfortunately, in the course of history, we've experienced destructiveness in the form of genocides and massacres in attempts to totally eliminate an entire race or culture. Thankfully, by virtue of the nature of our field, the compassion it takes to serve and support individuals with IDD almost guarantees that most of us do not start at level 1. Level 2 is incapacity, and while level 1 is intentional and purposeful, level 2 is unintentional cultural destructiveness. It's the lack of capacity of systems and organizations to respond effectively to the needs, interests, and preferences of culturally diverse groups. It's about having a biased system that may result in discrimination in hiring and promotion practices, or in allocating resources that may benefit one culture group over the other. If care managers are aware of their own biases, it really is unlikely that she or he will start at level 2. Level 3 is blindness, and unfortunately, this is a fairly common starting point towards proficiency. This is the condition of being unbiased, believing that culture, class, or color makes no difference. It's about viewing and treating all people as the same and using approaches in the delivery of services and supports that ignore cultural strengths and differences. Although this may be a well-intentioned strategy, it is ethnocentric in nature and therefore not person-centered. In other words, care managers would do a disservice to individuals if they believe that being colorblind or blind towards race or culture is a good thing. Blindness can also be about having institutional attitudes that blame individuals or families for their circumstances. Care managers should be aware of cultural nuances to support individuals and families so that the most person-centered and family-centered approach is used. Next is level 4, pre-competence. At this level, systems or organizations are aware of their strengths, weaknesses, and areas for growth to respond effectively to other cultures. Although efforts are made to improve service delivery for a specific racial, ethnic, or cultural group, the downside of this level is that there is no clear plan for achieving organizational cultural competence yet. Then, level 5 is competence. This is when there is an acceptance and respect for cultural differences. Staff are diverse and unbiased, and there is a continual assessment of sensitivity to other cultures. At this level, policies and procedures that integrate cultural and linguistic competence into each core function of the organization are implemented, and resources for both individual and organizational self-assessment of cultural and linguistic competence are allocated. Finally, level 6 is proficiency, what every care coordination organization strives for. At the proficiency level, cultures are held in high esteem, and there is constant development of new approaches seeking to add to the organization's knowledge base. Evidence-based health and mental health practices, interventions, training, and education models are published and distributed by the proficient organization. And other organizations receive support and mentorship as they progress along the cultural competence continuum. So which level do you think you're currently in? Remember, it is important to be kind and generous, but you still might be missing something, a cultural nuance that's important to understand so that you can coordinate the right services at the right facilities with the right resources. We are confident that most transitioning MSCs already have the necessary skills that will help CCOs become proficient in cultural competence. Now let's move on to identity development models. Identity development models provide a framework for care managers to be aware of the unique experiences and history that contribute to behaviors of members of specific cultural groups. Understanding these unique experiences and history guarantees higher quality and more effective care management. If you think that certain cultural groups act or behave in a distinct manner, your observation is correct. And each of these models are designed for a specific cultural group to help you examine and understand your own stage of cultural development by understanding those behaviors and mannerisms of other cultural groups. Typically, identity development models have stages. Those you see listed under the third bullet are Atkinson, Morton, and Sue's racial cultural model, Cross's Black racial model, Helm's white racial model, and Troyden's homosexual, gay, and lesbian identity model. These are only 4 of many identity development models, but this is a sample that provides a cross-section representing major groups in our current society. The goal is for CCOs to train care managers on the identity models that best fit the population they're supporting. These models are used so that healthcare professionals can better understand what the mindsets of specific cultural groups go through and what adversities certain groups needed to overcome. If you want to learn more about identity development models, additional resources are provided at the end of this PowerPoint. But another way to learn about cultural groups is by understanding the concept of diversity. We should all have an awareness of the history that contributes to certain behaviors, whether working with Native Americans, Blacks, Whites, Latinos, LGBT, etc. We have to be aware of their unique experiences. And this is why educating ourselves and educating others on diversity is so important to the work we do. Diversity refers to differences that make each person or group unique when compared to other persons or groups. To further understand concepts like diversity, CCOs will train care managers using specific learning objectives. For cultural competence, these are 2 examples of learning objectives that care managers may be trained on. One of the learning objectives requires care managers to be able to identify your personal biases and explain how they affect your role as a care manager. A learning objective of higher difficulty would be to promote a culturally sensitive and competent work environment on a daily basis. Now, understanding the definition and importance of diversity would actually be a good starting point to meet these learning objectives. Now that we have an idea of what it takes to have cultural competence, we can briefly discuss some strategies to deliver cross-cultural care and supports. It's important that care managers maintain curiosity, empathy, and respect. By curiosity, we mean to be curious about the individual's beliefs, practices, fears, and customs without crossing personal boundaries that may bring any discomfort to the individual or the family. By empathy, we mean putting yourself in the individual and the family's position to truly understand their circumstances, which will help you understand why they behave in a certain way. And no matter what you may hear from either party, always remain respectful and maintain professionalism. As you go through the cultural knowledge, cultural awareness, and cultural sensitivity stages, we suggest you start by understanding the individual's values, the meaning of her or his illness, her or his sexual orientation and gender identity, the family's cultural myths or folk beliefs, their immigration status and country of origin, the individual and the family's education level, and the individual's relationships with others. We hope that these are helpful strategies you can apply with the individuals starting at the intake and enrollment process and throughout transitions within and out of the OPWDD system. With that said, I'd like to ask the following question. During the intake and enrollment process, would you interview all individuals and their families using different approaches? Would you treat all individuals with respect, dignity, and humility, understanding that each person is unique? If you answered yes, you're correct. In a care management environment, care managers must provide families with counseling, education, or training regarding specific treatment regimens. This is because many health problems experienced by persons with disabilities can be prevented and or managed through health education interventions. Health education and health promotion are key interventions that will require different conversations during intake and enrollment. As shown in the bottom shaded area of the screen, persons with disabilities reported about 10 days of poor physical health in a span of 30 days, whereas persons without disabilities reported only about 2 days of poor physical health in a span of 30 days. If individuals and their families receive more health education about the physical and mental health conditions at hand, and if more health promotion supports were obtained, then the number of poor physical health days of persons with disabilities would be reduced. Intake interview approaches would also be different depending on the individual and family's preferred and primary language and means of communication. During the intake and enrollment process, a good care manager would not assume that the individual and family's primary language is English. The care manager would identify the correct primary language and ensure all information is communicated and distributed in preferred languages. The care manager would also make the necessary arrangements so that language is not a barrier to accessing services. The person-centered planning process requires care managers to ask about the individual's employment needs during the intake and enrollment process. As such, care managers should be aware that according to the Department of Labor, in 2016, only 17.9% of persons with a disability were employed. And of this group, people with developmental disabilities experienced the highest rates of unemployment. It is estimated the unemployment rate for people with disabilities is at 85%. As we mentioned, care managers must consider an individual's sexual orientation and gender identity to further understand and identify the support she or he needs, because research studies have found that the LGBT adolescents are at greater risk for depression, suicide, and substance abuse, and approximately 29% of LGBT adolescents attempt suicide at least once per year, compared to 6% of heterosexual adolescents. Now that we've covered the importance of delivering cross-cultural care and supports using different approaches, starting at intake and enrollment, let's continue to dig deeper into the definition of diversity. There are 7 dimensions of diversity, and they're divided into immutable dimensions and cross-cutting dimensions. Simply put, diversity refers to the differences that exist among all kinds of groups. Diversity goes beyond just race and gender and includes all kinds of differences. The 7 dimensions represent the types of differences and are also the lenses and filters we use and others use to identify people. Race and ethnicity, gender, and sexual orientation are those dimensions that are immutable or unable to change over time. Generally speaking, we're born with these characteristics, and they shape our basic self-image. These are the differences that people use to self-identify and often frame conversations. Now, the cross-cutting dimensions are age, language, socioeconomic status, and religion. These are the differences that we acquire and sometimes discard or modify over time. They also enhance our life experiences. As MSCs transition to a care manager's role, their role as health and social care professionals will evolve as they gain exposure to different disciplines in the medical and clinical fields. The expectation from care managers as culturally competent health and social care professionals will be that they start and continue to learn about other disciplines' areas of expertise, background, and values, identify individual roles and processes, acquire basic group collaboration skills such as communication, negotiation, delegation, and time management, manage transitions and handoffs using the right resources such as health information technology, acquire and retain conflict resolution techniques, learn to communicate a common language, and create and adhere to shared guidelines. I hope you have a better understanding of the concept of diversity and the many considerations that must be taken when serving different groups of people. And with that said, the next question should be pretty easy. Would you support male individuals differently than female individuals? If you answered yes, you are correct, and your answer is consistent with the person-centered approach. The differences between males and females with IDD are just as vast as the differences between males and females in the regular population. The 3 most common causes of death in males with IDD are cardiovascular diseases, respiratory diseases, and neoplasms. In adults with IDD, males have more cardiovascular problems than females, and females have more visual problems than males. In adults with IDD, females are more likely to have endocrine, infectious, and respiratory diseases than males. Females with IDD often have difficulty following text-based medical advice. Therefore, instructions should be delivered using accessible language, and written material should be avoided. There are many more statistics that support that females with IDD will actually require different treatment than males. For instance, studies have found that over 50% of women with IDD have mental health problems such as depression, anxiety, and psychotic disorders. In children, males have twice the prevalence of NEDD than females, and more specifically have higher prevalence of ADHD, autism, learning disabilities, stuttering or stammering, and other developmental disabilities compared to females. However, there are more than physiological and mental health differences amongst males and females in the IDD population. Healthcare disparities help us understand those differences closely linked with social, economic, and/or environmental disadvantages. Remember that differences are what makes a group diverse. Healthcare disparities refer to the differences in access to or availability of facilities and services. Healthcare disparities adversely affect people based on their racial or ethnic group, their religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. Case in point, testing for hereditary disorders. There are dozens of screening tests to identify and treat babies at risk of hereditary disorder. In 2000, only about 18 states screened for fewer than 5 conditions. And by 2009, 49 states screened for over 21 conditions. However, people from disadvantaged backgrounds are still less likely to receive screening services, diagnostic evaluations, or treatment interventions. Studies show that persons with disabilities actually experience more significant healthcare disparities, including poor overall health and more chronic conditions than the regular population. To understand healthcare disparities, OPWDD's training guide for care managers includes the learning objectives shown on the right side of the screen. Care managers will be expected to explain how healthcare disparities affect individuals and their families in terms of having access to and engagement in services. Care managers will need to be able to describe effective interviewing skills to better understand an individual's culture, which we briefly covered in today's presentation. Healthcare disparities go hand in hand with social determinants of health, an equally important concept that care managers should be familiar with in order to complete cultural competence as a skill-building area. Social determinants of health are the conditions in which people are born, grow, live, work, and age, and they're shaped by the distribution of money, power, the environment, and other resources at the global, national, and local levels. Social determinants of health begin with income and poverty levels. In general, people's socioeconomic circumstances strongly influence the quality of their health care. Children insured by Medicaid have a nearly twofold higher prevalence of any developmental disability compared to those with private insurance. An individual's and family members' level of education can also play a significant role in determining where the individual will live and work and the quality of the interaction the individual will have with her or his community. At the lower strata of socioeconomic status, there is more risk for mortality, morbidity, unhealthy behaviors, and poor quality of care. Health disparities can be seen as a constellation of risk factors and behaviors that occur more for some groups of people than for others. Now that we've covered health, cultural, and socioeconomic differences amongst people with IDD, I think you may be able to answer the following question fairly quickly. Would you agree that an individual of African American descent may have different diets and food interests than someone of Asian descent? Could foods from these two cultures maintain their integrity and still be healthy? If you answered yes, you're correct. As we know, individuals from different cultural backgrounds have the fundamental right to eat the foods they culturally identify with while maintaining a healthy diet. However, it's important to be aware that certain groups are at higher health risks for certain conditions. For instance, African American individuals are prone to different health risks than Asian Americans. Research indicates that African Americans are at the highest risk for heart disease, stroke, and diabetes than Asian Americans. According to the Centers for Disease Control, out of 100,000 deaths due to diabetes, African Americans account for almost 43% of those deaths, and Asian Americans account for 16.2%. The patient platform found that South Asian men are 50% more likely to have coronary heart disease than men in the general population. According to the Asian American Health Initiative, cancer is the leading cause of death among Asian Americans. They have the highest rates of liver and stomach cancers. I will add that research studies concluded the prevalence of schizophrenia in people with IDD is approximately 3 times greater than for the general population. And South Asian adults with IDD compared to white adults with IDD have higher prevalence rates for schizophrenia. As far as diets and food interests in general, research suggests that the rates of obesity and chronic diseases among individuals with IDD are higher than in the general population. Individuals with IDD generally have limited knowledge and skill regarding meal planning, preparation, and portion control. There is no other vulnerable population that needs health education and health promotion opportunities more than the individuals we support. And so the expectation is that care managers identify as health and social care professionals who provide diverse populations with high quality care that is safe, person and family centered, evidence-based, and equitable. Caring, integrity, diversity, and excellence are core values that care managers should uphold. All levels of care provided must promote health, healing, and hope in response to the human condition. Integrity is upheld when we respect the dignity and moral wholeness of every person without condition or limitation. Diversity is encouraged when we affirm the uniqueness of and differences among persons, ideas, values, or limitations. Excellence is delivered to individuals and their families when transformative strategies with daring ingenuity are created and implemented, such as this systemic transition going from MSC to care managers. Ladies and gentlemen, this concludes our presentation for today. I'd like to thank you all for welcoming the NIAM team. We absolutely know that MSCs have been and will continue to be the backbone of our system, and we're committed to supporting you throughout this transition and after. Thank you for your many years of service, and we continue to look forward to our work together in the years to come. Please welcome Dr. Elizabeth Corrigan and Dr. Gilbert Lewis, who are also part of the NIAM team and will be helping with answering some of your questions. Once again, thank you.
All right, so our first question for NIAM is, are there any more recent references for the diversity models that you referenced?
This is Gilbert Lewis. It seems to me that in the context of cultural competence, the ones that we have cited are the ones that we believe are seminal, and any model that has come afterwards basically modify the original models. But what we know is that these models have been tested and are the kind of models that one can use to begin understanding people we support, as opposed to new models which tend to be focused on business or perhaps personnel management. These models that we've offered are pointedly for understanding how different cultures, different groups, different ethnic groups, different people with differences can be understood.
Thank you. The next few questions that we have are for staff at OPWDD. This first question is, there is a lack of staff presently available to provide services to people who do not speak English, and this is not something that a care manager can always control. Does OPWDD have any advice on how to handle this?
Hi, this is Allison McCarthy. I think we hear your concerns and the challenge. For this CCO implementation, we don't have a direct response in terms of resolving that issue and it being a potential challenge among direct service providers. Currently today there is funding supporting providers' services, and that negotiation continues, and we have various work groups discussing how that rolls out. So, again, I don't think the CCO model can specifically address it, and we do recognize and understand some of those challenges.
The next question is in regards to the toolkit. We received several questions as to when the toolkit will be available and if MSDs can begin meeting with individuals now to start enrolling and going through the enrollment process.
The toolkit, this is Diane Hanks, the toolkit is being finalized probably as we speak right now, and is starting to be posted on the OPWDD website. We anticipate it should be completed and posted by tomorrow so that you would have all of the different elements of the toolkit on the website. That toolkit will also be included in the SLMS training on enrollment and consent when that gets posted sometime later this week. In terms of the enrollment process, I believe that the plan that's been laid forth is to say that the process should begin after April 1st. The MSD provider agencies are being informed via letter about all the individuals within their MSD service provision, and those letters will go out to the provider agencies starting today. Then they'll be funneled through to the MSDs, and Allison, you can correct me if I'm misstating anything. And so, and the training will also be available within the next day or so. So at that point, once the MSDs have taken the training and have understand all the elements that have been offered to help begin this transition process and educate families and individuals on the options that they have, then you could begin to work with them. The Choices program will be ready to accept the actual choices from individuals as of April 15th. So you can't actually document the choices until then, but after April 1st, you could begin those discussions. Allison, would you want to add anything to that?
No, I think that covers it. I think it will be phased in regionally in terms of distribution of letters. We're going to work as quickly as we can to push those out to the MSD providers.
Alrighty, and that concludes the questions that we received related to the cultural competency topic today and on the toolkits.
Okay, then I just want to again thank Noelia Mango and all of our colleagues from NIAMP for putting this together for us today. Clearly, the cultural competence issue is one of the major skill areas that have been identified by OPWDD as being extremely important for MSDs transitioning to care managers. So this is certainly not the only discussion that we'll want to have about cultural competency, but it was a good foundational one to get us started. And so we hope it is helpful to you. It will be posted on the OPWDD website as soon as we can. And we thank you very much and ask you to join us again on April 11th. By then, the enrollment process will be underway, and we anticipate you will have additional questions. So thank you, everybody. Have a great day.